So I'm not going to give answers, but just raise further questions. So clinical stage is T in situ. T1A are all cancers less than 10 millimeters on the scans. And then you have 11 to 20 CT1B and CT1C 21 to 30 millimeters. And you have the equivalent pathologic classifications. So how well do they agree? And there is importance in coming up with the correct clinical that agrees with the pathologic, because that really determines the treatment, particularly of things like SBRT or where you don't do the resection. So how well did we do? So we had 5 cases of CTIS that were in agreement, 106 CT1A, 205 CT1B, and 66 CT1C. So correctly, we classified less than 50%, 46.2% were classified correctly among 827 clinical stage 1A. And if we looked at within the agreement within subcategories, not overall, then for CTIS, it was only 9.4%, 5 of the 53. And for CT1A was 57%, a little better. CT1B, 54%, and CT1C, 31.6%. So those are usually classified. That rating is a poor rating because all were less than 60%, although the CAPA said there's fair agreement, but we all agree that we should be able to do better. So in the clinical stage was higher than the pathologic stage in 14%. And when we look at the particulars of that, clinical stage was higher than the pathological stage for 53 of the clinical CTIS. They were all in non-solid nodules. 48 were found to have pathologic components, invasive pathologic components. That's why they were rated higher. But all of them had 100% survival. So is the CT findings more correct than the pathologic findings? They all had 100% survival. And so the current pathologic stage may overestimate the aggressiveness of these cancers, leading to potential overtreatment. And so we really think that CT features should be considered in the pathologic stage. And I think Dr. Travis always says that you should look at the CT images. But there's a lot of work to be done in the future. Now, clinical stage was lower than the pathologic stage in 39%. So 326 of the 827 patients. And if we take some of the most identifiable reasons, so among the 827 patients, 72 had an additional cancer identified in the pathologic specimen. So it was not seen on the CT, but it was seen on the pathologic specimen. And so now how do we differentiate between, is this a new primary? Is this a separate primary, or is it a metastatic lesion? And the treatment really is dramatically different for these two. So there really has to be much more work on this differentiation between a new primary and metastatic tumor using genetic information, as Louis has worked, and there's an accepted paper on that. And we really need to carefully figure out when should we call it a primary or when should we call it metastatic? And it shouldn't be based on the data that we have on bigger lesions, because these are smaller lesions and we're seeing that these weren't even seen on the CT scan. Pleural invasion is another reason for upstaging from a T1 classification, from a clinical classification to a pathologic classification. And pre-surgical assessment of visceral pleural invasion is difficult. And should it really lead to a higher pathologic staging? And should it be separated from vascular and lymphatic invasion? We had looked at this and we'd reported this, but there needs to be more action on this, I think. So here we see that the top lines that are all essentially equivalent are when you have none or just parenchymal invasion or just visceral invasion. The only time it gets worse, that the survival is worse, is when you have both visceral and parenchymal invasion. And when we look at subsolid nodules for in these cases, they're all 100% survival. So we think that pathologic that visceral pleural invasion needs to be separate, again addressed in small lung cancers. Again, the change to higher classification is mainly done on larger lesions, and it's very different when you have smaller lesions. So that's the end, and we wait for pathology and other data to come in to make this further classification.